it's my great pleasure to introduce Professor Ian Olver to everyone. Ian's a cancer researcher and bioethicist who practiced as a medical oncologist for over 20 years. He's currently the Professorial Research Fellow in the School of Psychology, Faculty of Health and Medical Sciences at the University of Adelaide. His previous roles include Clinical Director of the Royal Adelaide Hospital Cancer Centre, CEO of the Cancer Council, and he also sat on NHMRC Australian Health Ethics Committee for 9 years, chairing it for 6 of those. He's also chaired the Medical Oncology Group of Australia Ethics Committee until 2020. His PhD in bioethics is from Monash, called A Highest Value on Life, Ethics for Life and Death Decision Making. So with all of those amazing experiences and years of thinking in the space, Ian is uniquely well placed to talk to us this morning about opt-out approaches to consent. So a very warm welcome to you, Ian, and we look forward to your presentation. So I'll hand over to you. Thank you.
Thank you very much, Eleanor. It's good to be with you, and I'm excited to talk about opt-out consent. During my time as chair of the Australian Health Ethics Committee, that was one of the issues that came up, and the issue of whether we should include opt-out consent in the national statement. So the issue is that normal consent in most human research, the potential participants are provided with detailed information so they can make fully informed choices about whether to participate in a project. And this requirement for this explicit individual consent reflects really the value that our society places on individual autonomy. So in 2013, the national statement neither included nor in fact specifically excluded opt-out consent. I mean, it had explicit consent, and it in fact had a waiver of consent, but nothing in between. And what we're talking about here, and I know there's a controversy about whether it should be called opt-out consent, because some people don't believe it fulfills the criteria of consent, but because that's the common term, I've chosen to stick with it here. And what it requires is that following the dissemination of information about a project, and that's important, you've got to have made a good attempt to get public information out, the consent is presumed by the participants unless an individual actively withdraws the consent. And it's challenged really because there's no way of knowing whether every individual may or may not be informed, but certainly in the hierarchy of consent, it certainly allows more autonomy than a waiver, so to that extent it can be justified. I guess the other comment to make was when we were considering this, as I'll talk to you about in a minute, we discovered that many ethics committees around the states, around the country, were in fact granting, particularly to registries and things, the option of a sort of an opt-out consent for large epidemiological projects, rather than just going straight to a waiver of consent. Now, one of the difficulties with explicit consent, if you need to do a project where the accuracy of the findings depends on the completeness of the sample, and if you're analysing a registry, for example, and you're going to make policy decisions, you really want to make sure that the people you analyse are as full a representative of the sample as possible. And yet research on explicit consent shows that it's generally associated with a recruitment rate of something between 30 and 50%. And people have all sorts of rational and non-rational reasons for not giving consent to research in some situations. So it's highly likely that if you had this sort of level of recruitment, that the participants could be unrepresentative of the whole population, and therefore the result that you get out of it will lack credibility, whether it be for a quality improvement activity, whether it be as part of a benchmarking exercise against other populations, or perhaps more importantly, if it's for policy making, and it's important to get it accurate. And just as an example of that, if you use opt-out consent, which at the time the Victorian State Trauma Registry were using, probably still do, with over 15,000 people on the registry, they found that when they did studies on the registry, there was a recruitment of less than 0.5% patient withdrawal. So many registries were using opt-out to be able to analyse their registry. So what sort of uses does it apply to? Well, it could be linking large digital databases in order to ask questions about clinical practice. So, for example, you might have hospital registration data linked to a registry, and that's what happened when they were doing some work on esophageal or esophagogastric cancer, and they wanted to find out what influenced the outcomes, and actually found it wasn't about surgeons or individuals, it was about the number of procedures that a hospital did. And that was important because you could then say, well, this is a special procedure that could only be done in a limited number of hospitals. That was work from New South Wales published a few years ago. The other reason for opt-out consent is if research on healthcare standards would be critically compromised if you didn't use an opt-out consent for the reason of not being representative. And then there's simply the impracticability in epidemiological studies of obtaining explicit consent. So, for example, if you wanted to go into a registry database and have a look at the correlates of occupational exposure and disease, you may be able to access the records, but you almost certainly wouldn't be able to get explicit consent from every record there. It'd be difficult to trace ex-workers to obtain that explicit consent. So there were genuine reasons for the quality and integrity of the research for wanting this type of consent to be considered. And 3/4 of the registries, clinical quality registries that collect and analyse information from groups of patients were in fact wanting this approach. Now, the national statement, as I said, had waiver of consent, and it was instructive to us to see what the conditions that were put around waiver of consent in the national statement. So it had to be granted by a Human Research Ethics Committee after looking at the nature of the project. It had to be low risk, and I'll talk about low risk in a minute. The benefits of the research have to justify the risk. Now, what we're talking about in benefits and risk, the major risk or concern about this type of research is if you could identify individuals out of a large data set. And so, but the point is that the type of research that's being done will not only benefit a population, it could ultimately benefit an individual. If, for example, as I gave before, you were looking at sort of occupational correlates of disease, and you could counsel people about occupations if you found an association. We've said it impractical to obtain consent, which in the waiver thing was large numbers of records. The other one for waiver was there was no reason to think participants would not consent. So again, in the occupational example, it would be difficult to suggest that people might not consent to that. But if you were doing some work into, say, the correlates of sexuality or something, you might believe that people may not want their data to be used in that way. So the waiver required no reason to think participants would not consent. There had to be the sufficient privacy protection in place of individual data. Now, many large registries are essentially de-identified data sets, but in the days of data linkage, I think the algorithms and things used to protect individual data have become pretty well practiced. And The research results should be provided to the group on which you've done the research, particularly if it's going to improve the welfare of those people. And any commercial gain would not deprive participants financially. So that was unlikely, I suppose, but it was a possibility that someone might be disadvantaged by the results of such research in a waiver. And so in terms of the waiver, the other sort of conditions was, given the importance of maintaining public confidence in research or the process of research, it was the responsibility of each institution to make available summary descriptions of what they were doing, for example, in their annual reports, and to make it clear in what situations and what projects consent had been waived. But however, it was thought desirable that waiver decisions should not be made publicly accessible until the research had been completed, in case there was a compromise in that situation. So what about the opt-out approach? Well, an opt-out approach to participant recruitment in research may be appropriate when it's feasible not feasible to contact all of the participants. But if the project was of such scale and significance that using explicit consent is neither practical or feasible. So there's it's, as I say, a step up from waiver, because you do in opt-out consent have to make an attempt to publicly disseminate what research is being done. Again, it had to be low risk research, and I'll define that in a minute. Again, the public interest from research had to outweigh any privacy concerns, and indeed the research would be compromised without it because of what we've said before, low participation and a biased or unrepresentative sample. And the participants in the group, though, and this is unlike waiver, not only had to be given the information, at least in a public form, before the project was done, but they also had to be given specific instructions about the opt-out procedure, how they would opt out, and they had to be given time to opt out before the analysis occurred. And of course, the data security standards required by privacy had to be maintained. Now, when you are talking about consent, either opt-out consent or waiver of consent even, research projects have to comply with the Code of Fair Information Practice. So the operating principles and technical standards for clinical quality registries, they had to be adhered to with the opt-out consent process, and the operating principles and indeed other state-based or federal legislation had not to be compromised either. Now, the question of low risk has come up several times, and basically low risk meant where the only foreseeable risk is no more than discomfort. If the risk, even if unlikely, is more serious than that, then the research is no low risk. And that pretty much cut out doing any sort of, say, randomized study. Even if it was a fairly benign sort of study, you couldn't say that the risk would only be discomfort. So we're really talking about these sort of large population-based studies. A negligible risk, which was the other term used, is no foreseeable harm or discomfort, or slightly looser, the foreseeable risk is no more than inconvenience. And again, if it's more than that, the research is not negligible. So although for convenience, I guess people may want to stretch the definition, it's been ring-fenced a little bit by this requirement for low or negligible risk research. Although it's interesting, in a discussion I was having the other day, somebody wanted to do a series of randomized trials, but the research they wanted the opt-out for was to, once the de-identified data sets from all the trials were available, they wanted to compare them. So it was in the context of a randomized trial, but they were going to get explicit consent for the trial, and then it was the add-on of the comparison that would be the request for opt-out. Now, what about this comparison of opt-out versus explicit consent? And I think to a certain extent, we would use the same principles. So individual privacy must be protected in opt-out, just like it should be in any other form of consent. And that means that in the document describing the research, the spectrum of activities for which the participants can be recruited should be very clearly articulated. As I said before, the information about the process has to be provided. And there are many ways of doing that. The mass media is an obvious example, but in hospital-based research, there are hospital admission packages now that talk about the sort of research that may be done on the accumulated data from patient admissions. So you might make the possibility of research projects of that nature, the information is given just in a hospital admission package. But it has to be said that unlike explicit consent, there is no guarantee in opt-out consent that each individual has read the information. However, I would make the point that even with explicit consent, there are few guarantees that even if they've read the information, that the degree of understanding would qualify for informed consent. And many trials have now shown that the recall of information after reading an individual consent form is poor. We actually did a study some years ago with chemotherapy patients, and we did it both with patients who are on clinical trials and reading the very detailed consent forms of clinical trials, and we did it in patients who were just having routine chemotherapy with our standard consent forms. And we actually surveyed the patients when they came in for their second course of treatment, which in just about all cases was only 3 or 4 weeks later. And what we found was that just 2 of the questions, how much of the consent form did you read? Well, only 80% of the patients read all of it, 4% passed of it, 11% quickly skimmed it, 3% did not read it, and 2% said they couldn't remember, which means they did not read it but didn't want to tell us. How much was understood? And we got 60% only said they understood all of it. So 4 out of 10 people that signed up to do a research project didn't understand the implications of that project. 26% understood most of it, some of it, none of it, and I can't remember, I do not read. So I don't think we guarantee understanding even when we get explicit consent, because we never really sort of test for it afterwards. Interesting thing is there's been a couple of randomized, well, there's been more than that, but I want to show you a couple of randomized trials looking at opt-in and opt-out processes. And this trial was a single blind parallel group randomized trial of a group of families with babies born at a South Australian hospital that were sent informed consent documents at 6 weeks, and they explained a project of data linkage of childhood immunisation with hospital records, and it was about vaccine safety surveillance. So they explained, what they were going to do with the data and so on. And the patients were either split into groups that had 4 weeks to either opt out if they're in the opt-out group or sign up if they're in the opt-in group. And they followed up 10 weeks later by a telephone interview. And in both the opt-in and the opt-out groups, 4/5 of the patients recalled receiving the information, so they remembered reading the data they'd given. 3/5, however, similar to us, reported reading it, but only 2/5 correctly identified the purpose of the study. In other words, what data sets were to be linked. And so while recall and understanding of the study was actually better in those who actively consented in the opt-out group compared with parents who only passively consented by not opting out, the key thing here, as we said right at the beginning, was that the participation was substantially lower in the group that had the option of opt-out, so versus opt-in. Sorry, the group were lower in opt-in. So 21% of the group, given the opt-in, actually agreed to the study. 96% of those who had to opt out agreed to the study. So the findings were that most parents appeared to have a relatively poor understanding of the data linkage for vaccine safety surveillance. And when they were asked if they were interviewed, whether they thought that this sort of data linkage project was a good idea, most of them did. And frankly, they preferred a system using opt-out or no consent because they didn't want to engage in the detail if the sort of principle of the study was okay. So I think that reinforces some of the things we've been talking about. A more recent study was looking at opt-out versus opt-out consent on deceased organ donation and transplantation. And of course, one of the problems we have is low transplantation rates or agreement to it. And there was a systematic review done to determine the effect of opt-in versus opt-out consent on the deceased donation rate and the deceased transplantation rate. And this review looked at 2,400 studies in screening ways and included 6. And basically found in the results that of the studies that there was, again, a big difference in the deceased donation rates and the transplantation rates depending on opt-out consent. And there was quite a significant increase in both the donation rate and the transplantation rate if the patients were consented in the opt-out way. So in conclusion, so I can leave some time for questions, explicit consent is the gold standard. Opt-out consent really provides an additional tool for a very small subset, but important subset for low-risk research, where it's only about sort of inconvenience or minimal discomfort, where there's significant community benefit to counteract any concerns over privacy, and where near to complete participation actually is achieved so that you don't compromise the result that you're trying to get. And so, but in the national statement, it purposely doesn't cover every possibility. I mean, it gives general guidance, as I've talked about here, but research ethics committees need to apply to that general guidance in the specific research case that's presented towards them, because we recognise that there is absolutely no way that we could cover every possibility, and so we leave that to the individual ethics committees. And I'm happy to be contacted by anyone who has follow-up after the presentation.
Lovely, thanks so much, Ian. That was really interesting. So we've got a question on chat from Jessica Court, and she's referring to the data that you presented about parents, not read, or people that come back for second rounds of cancer treatment, that they look at things or they skim through it. 60% of them don't really understand it. Jessica's question is, does this suggest that there should be a standard of consent forms should have a highlights or takeaway section on the first page, like a short summary of key points at the very beginning to assist people assess whether they consent or not?
So it's a very good question, and we actually followed up that study with a study of presenting the consent in other ways. And in those days, it was about the startings of electronic documents. So we made CD-ROMs and we gave them out with frequently asked questions, with a lot of other information that they could access. And we found it made absolutely no difference, because the problem was the timing in which we were giving this, when patients were anxious, they wanted to get on with their therapy, And so what we found was that the solution to the problem would probably be to make sure you repeated the information over subsequent courses. And so by the end of the treatment, they would understand it completely. The other thing we found was that the lack of understanding did correlate with the degrees of anxiety and depression. And so they needed to be addressed before you could make impact on it. So it wasn't the mode of giving the consent, it was the fact that you actually needed to give it over time when someone wasn't stirred up by their diagnosis and impending treatment.
Yeah, no, that's a great point, and it reminds me of the work that Neil Pickering and colleagues did in Otago when they spoke about the ethics of ordeal, that you can't consent to something that's going to be such an ordeal that you don't know what it is until you're in it.
Yes.
That's a separate problem. But there's another question on chat here. What do you think are the best ways to increase participation in hospital research? Do you think an opt-out approach is warranted here?
Well, I think the problem is, unless you're doing what used to be sort of called quality assurance activities, and there was always an unwinnable argument about where the line between quality assurance and research was. So I think people have abandoned that and gone back to looking at other things. Unless you're doing that sort of study, most hospital research does involve more than low risk to participants under the definitions I've given. So I don't think there would be a possibility of waiver there unless, as I say, you were doing this sort of quality type research where you're just interested in the aggregated total of de-identified data bits. And then I think opt-out, which could be advertised, as I said, in the hospital admission information given to patients, would be quite a reasonable way of approaching it.
Lovely, thank you. So we've got another question here from Ben Canny. Can you provide any data on the Australian public attitude towards registries and databases? We've got evidence from the My Health record take-up, but are there other data available, thinking about reports of the general acceptance of data linkage in Scandinavian countries, for example?
I can't quote the specific studies. I can quote studies that have looked at various aspects of it, but in general, a bit like the study I quoted, people, it depends how the information is presented. And I think the real key here is that people have got to understand that the data provided from analysis of registries and so on is actually in the public good. It helps the individual. So it's not about satisfying researchers or giving your data to a government to do what they will with. It's about your well-being as a population. So I think the studies that have been done depend on how you present it. And the trouble with some of the My Health record stuff is that, and the press haven't helped this, is of course some of the negativity about compromising of data or what's going to be done with the data. But it must be underpinned that you're doing it for your own good, not just everyone else's, and certainly not just for the government.
Lovely, well, thank you. And just for everyone's benefit online, I'm happy to post a link to a paper that I published last year with 2 Griffith colleagues, interviewing patients in a clinic about their attitudes to research and who they trusted to have their data. And it was very positive, actually, which is good. I think it's good news for the future of research that obviously the population still have a degree of trust in researchers and in health professionals. So I think that's really great. So I'm just mindful that we are 1 minute to the end of our session, Ian. So unfortunately, I'm going to have to leave that last question, but we might have time for it at the end of the next presenter session. But Ian, just wanted to say thank you so much for that really important and timely presentation. And I'm sure we've all got much food for thought to take forward into our roles and lives in ethics committee work. So thank you so much.
Thank you, Eleanor. My pleasure.